Wonderful. I think the recording has probably started. My name is Janna Gerwirtz-Obrien. I am a pediatrician and an adolescent medicine fellow here at the University of Minnesota. I'm in what's called the Leadership, Education, and Adolescent Health Interdisciplinary Fellowship. So if there's questions about that, I'm happy to talk about that too. But today we're going to be talking about vaping and the developing brain. We'll be talking about how big tobacco is capitalizing on their knowledge of adolescent brain development to recruit new adolescents to the ranks of tobacco users. And then we'll talk about what healthcare professionals, like many of the people it sounds like on this call are doing, can do about it. So I'll talk you through kind of the game plan for this, but I would love to hear a little bit about who is on the call, and I'm already seeing some people utilizing the chat feature, so thank you. I'll try and check in on the chat periodically as well. All right. So I'm going to just start with some disclosures. I have no financial disclosures at all. But I did want to disclose that I'm on the board of the American Academy of Pediatrics Minnesota chapter, and I actually share in this webinar a few resources that are from the AAP. And though I know there's a range of disciplines on this call and on this webinar, I really think a lot of those resources are quite useful and provide some really nice background. So I'll share some resources from there as we go. My other caveat is that I'm not a neuroscientist. I am a pediatrician and I'm an adolescent medicine doctor. I mainly see teenagers in practice, but I have found that reframing adolescent behaviors and thinking about dependence, addiction, substance use in the context of adolescent brain development has really reframed my own practice. And hopefully I'll share what I've learned with you. All right. So I'm actually going to start by providing a little bit of context about how I ended up here before we even go through the game plan for today or our learning objectives. So I wanted to share with you a little bit about the first young person I met who was using an e-cigarette. And this was a young man I met working at a school-based health center. He was about 15 years old, and I was actually seeing him for the first time for anxiety and for worsening asthma. And the school nurse had sent him down because he was having an asthma attack, and he shared with me that it was triggered by his anxiety, which is not uncommon. And I met him for the first time, and we were talked about a whole lot of things. And when I screened for tobacco use, which I do consistently, especially in the school health setting, he mentioned that he uses e-cigarettes, and he was actually proud of this because his family mainly used cigarettes, and he said, "Well, I only use e-cigarettes." And I was like, "Oh, well, tell me more about that. I didn't know much about these devices." And actually, the whole time I'd been talking with him, he'd been holding this little thing that looked like a key fob, and I have a picture of it here. It was a Sauerbrunn drop, I now know. He was holding it in his hand during my encounter. I actually think he put it up to his mouth during my encounter, and I didn't even know. So he opened it up for me, and he showed me that it looked like this. So you can actually open it, and you can put some fluid in there, which I now know contained nicotine. And he shared that he was using it to lower his stress, and that he only uses it every once in a while, every few weeks, and he was proud of that too. He was not using consistently. And unfortunately, I continued to follow him over time, and he is this great young man, and though his asthma started to improve a little bit, his anxiety progressively got worse, and he became a daily user. So a few months later, when I saw him after he'd returned from summer break, he actually was using this device daily. And now, knowing what I do know about these products and about the adolescent brain, I realized that Big Tobacco had actually planned this. This is very much exactly what they wanted. They wanted him to use intermittently, and they knew that very likely if he started using intermittently, he potentially would become a daily user who would persist there until adulthood. And I also know now that his e-cigarette use was likely also contributing to his anxiety in addition to his asthma. So I've come a long way from there, and I've learned a lot about this issue. I've become increasingly involved in primary care and school-based efforts to improve adolescent vaping and reduce the risk, but I'm hoping with all of us, that all of us together can think about how we might act in this situation now if we were to learn that someone right in front of us had their e-cigarette device on them and was using. Okay, so we'll talk about the game plan for today, and I'd love to hear a little bit about what you're hoping to gain from this, but first, the first quarter of our talk, we'll talk about trends in adolescent e-cigarette use, and this includes the intersection between e-cigarette use, mental health conditions, and substance use, because I want to talk about the overlap, and I think judging from the list I've seen so far, it sounds like we have a number of mental health professionals and social workers and a number of people who work with substance use and also in foster care. Next, we'll summarize the current literature on the effect of nicotine on the developing adolescent brain, and we'll think together about how that can inform our work. Third, we'll describe the link between nicotine and other substance use. And then fourth, we'll talk about several clinical and community-based strategies for addressing adolescent and young adult e-cigarette use. So I'll keep looking and seeing if there's anything else that people want to know, but I think we'll cover most of what's been asked so far. Thank you all who've responded. But big picture here, when you walk out of this virtual door, I am hoping that we'll all be thinking a little bit differently about adolescent brain development, be thinking about how mental health and substance use play into this, and in the setting of nicotine use. And I'm also hoping that we'll all be thinking together about our roles and what we can do about this epidemic. So what about you all? I'm going to go back to my chat and scroll through and see if there are other things that we'd like to cover here. All right, so youth substance use prevention programming. You're in the hospital setting, great. We can talk a little about that. We have some social workers here, as I mentioned, great. People just wanting to know a little bit more about what they can do. Thank you all for sharing. And it looks like also we have people from all over, including some folks from warmer climates. Lucky you. All right, and social worker with immigrant youth. Okay, an area of interest of mine as well. All right. We're actually going to start with a word on a brief word on terminology. So you'll notice that the title of my talk actually included the term vaping. The reason why I use that term is it's a term that most of the adolescents who I see in my practice use when they're describing these products. It's also a term that was very likely strategically picked by the tobacco industry, and that vaping connotes that it's just water vapor, it's safe, it's a simple substance. But really what we know is that actually these devices heat up liquid into an aerosol form, which is not actually a vapor. The main term that I'm going to use throughout the rest of this talk are e-cigarettes and the next one I'll talk about are electronic nicotine delivery systems. E-cigarettes I see are most often used in the media and are often used in the public health world. That's the main term that's used there. And what these refer to are, again, devices that heat up a liquid that 99% of them contain nicotine within this liquid, include other additives as well, oftentimes some flavoring, which we know helps recruit adolescents, heats it up into this aerosol device. Electronic nicotine delivery systems, again, e-cigarettes are one of them, and this refers a little bit more broadly to devices that are, all devices that are used to inhale nicotine. Specific products, so I think it's also important that we as people who are working with young people and with adults who are using these products also know the language that they may use. And I frequently hear adolescents describe what they're doing as juuling. So they've turned Juul, which is a brand, into a verb. They also talk about blue, smock, sourin, and cigalikes. And these are all just refer to specific types of electronic nicotine delivery systems in e-cigarettes. So here we are. And I wanted to show kind of some pictures of what these look like, because I think the first step here is identifying them when an adolescent is sitting in front of you and holding one in his hand. And these devices, you can see on the periphery of the top line, they initially started looking like traditional tobacco products. So cigarettes, pipes, and cigars. But as you kind of move inward, you can see that they start to look a little more technical, a little more modern. You can see some pen-looking devices and a mod in the middle there, that big rectangle. And then on the bottom, this is the kind of newer generation that look very sleek and very easily concealed. And we think that this is why, another reason why this might be appealing to adolescents is that they're easy to conceal. Many of them look like jump drives or like key fobs, so everyday devices. And in fact, when I go and talk about this at schools, there have been a few instances where I enter the school and the principal will say to me that they just found one of these devices plugged into a computer at the school that day. This has happened now twice to me when I was at a high school speaking, that same day they had found one of these devices in the hall or in a computer plugged in. I will talk briefly about the anatomy of electronic nicotine delivery systems. There is actually a great webinar earlier in this series that talks about the pharmacology and the anatomy a little bit more. But just to make sure we're all on the same page, most of these devices contain a battery or an energy source that heats the liquid that's oftentimes kept in a tank of some kind, and then it's inhaled and dispensed into an aerosol form through the cartridge or the drip tip. But again, these devices can look a lot of different ways, as I shared before. They can be classified based on the technology of the device or the way they look. And again, this can be a useful way of thinking about them, going from the kind of older devices like e-pipes, e-cigars, and all the way on the right, e-cigarettes, to the more modern devices that are large-sized tank devices, medium-sized tanks, and rechargeable e-cigarettes, which can be charged oftentimes, as I mentioned, by a USB. All right. So now that we're hopefully all on the same page about technology, we're going to talk a little bit about the trends. And I'm going to present national data, but since many of us may be in Minnesota, I'll also share a little bit of Minnesota data too. So what you can see here are that according to the 2019 National Youth Tobacco Survey, about a quarter of adolescents reported using an electronic cigarette in the past 12 months, or in the past 30 days, sorry. And you'll see that the numbers I use are primarily going to be past 30-day use. So these are not young people who have used maybe once in a lifetime. These are young people who have used recently. And about 1 in every 4 used e-cigarettes in the past 30 days nationally. And these are high school students. When we look at middle school students, about 10% of them had reported using in this 2019 survey. That represents about a 20-fold increase from 2011. And though this isn't the prettiest slide, I actually do think it shows some important trends. So what you can see here, I'll first highlight in red the cigarette use, and you can see from 2011, which is represented by the white bar, down to 2018, you can see there's been a nice steady decline in cigarette use, and public health has really worked hard to get to that decline. And this compares with e-cigarettes, which have generally been on the rise. And you can see there's been a tiny dip in 2016, 2017, but then 2018 we're back up, and now 2019 we're even higher. And unfortunately, we're seeing a rise in all tobacco use as well. Again, which I think would we could easily argue is what big tobacco wants. With Minnesota data, we're seeing similar trends, so we are not an exception to the rule. What you can see here is that in grade 11, about 5% of young people in 2016 were using, compared to now, in grade 8, about 5% of young people were using, compared to 11% here in 2019. So this is 2016 to 2019. And when we look now at 11th graders, about a quarter of 11th graders were reporting using in 2019, and you can see this rise from blue in 2016. All right, I did want to make a brief comment about dual use. So one of the big messages that we're hearing from these vaping companies is that e-cigarette products are tobacco cessation products, or nicotine cessation products, excuse me. And in fact, many times when I'm in Walgreens or another pharmacy, in the back behind the counter, there's a whole group labeled cessation products. And that's where e-cigarettes can be found. But I want to be very clear that there's no evidence to suggest that e-cigarette products are actually nicotine cessation or tobacco cessation products. And in fact, for adolescents, most of the time, e-cigarette products predate combustible products. And here in Minnesota, about 60% in 2016, 60% of Minnesota high school students reported using both. Here we are. I did want to mention, at least briefly, the epidemiology of e-cigarette use in mental health. And I wanted to actually start by saying that actually young people with more severe mental health conditions are even more likely to initiate use. So before we even get into the neuroscience behind how e-cigarettes affect the brain, young people with more severe internalizing and externalizing problems are more likely to go on to use tobacco products more generally. And what you can see here is that with each progressive darker gray color, adolescents were more and more likely to initiate use. So again, this is really concerning and may affect the young people with whom we work. It's also well established that there is a significant overlap between people with mental illnesses, including serious mental illness, and nicotine tobacco use. And this has been shown epidemiologically and also in animal models. E-cigarettes and other substance use. So we know that young people who use e-cigarettes have about 8 times greater odds of reporting severe substance use symptoms compared with those who did not smoke. And this was in a nationally representative sample. And this equates to about 20% of young people reporting severe substance use symptoms, of young people who use e-cigarettes reporting severe substance use symptoms. So again, there is this epidemiologic link, and we're going to talk about the neuroscience behind that. And we also know that this is no accident, and this is a graph from the CDC, but even though it's from 2011 to 2014, it showed that with progressive increasing spending in e-cigarette advertising, there has also been a corresponding rise in past 30-day e-cigarette use among young people. And this goes until 2014, but now there have been several studies that show that young people are particularly susceptible to e-cigarette advertising and do respond to it. So though this is correlation and not causation, we now have some studies that show that adolescents are particularly susceptible. And though the executives of Juul and other big tobacco companies went and testified actually before Congress that they were not marketing directly to young people, ads like this from Juul might make us think otherwise. And millions of dollars are spent every single year in advertising. And though it's not specifically meant to target young people, they say that it's not specifically meant to target young people. This is clearly a young person smoking a Juul in this ad. And then again, just to further kind of back up the argument that they very likely are targeting young people, these are some of the candy and sweet flavored e-liquids. They oftentimes call them juice. And you can see there's Fanta flavored, there's Candy King and different Candy King flavors, some cereal fruit pastel flavors. And then I think the most unfortunate and telling is this back to school blowout sale at an e-cigarette shop. When I first saw this, I think this really kind of sealed the argument for me that vape shops are absolutely targeting young people. And then one thing that's new, so much of this is kind of taking a page from Big Tobacco's longstanding efforts, but one thing that's new is that they've been very strategically using social media. So a lot of the young people that I work with report seeing ads from influencers or from these companies that directly kind of product place e-cigarette devices in the hands of influencers on social media. And I've shown a few here from Blue kind of doing just this. And here in Minnesota, about 88% of young people reported in 2016 that they had actually seen an advertisement for e-cigarettes in an ad, and oftentimes through social media. And again, this is Big Tobacco using the same old tricks. So this is not a new kind of page. This is an old page in the tobacco playbook. And you can see Marlboro actually now owns stock in Juul. And even though Juul is relatively young, Marlboro is definitely a part of this. And you can see this older ad showing this young person smoking, looking very cool, if I may say. I can't tell if you all are laughing at that, but look at this. He looks very cool and dapper, sitting in front of his school locker, smoking a cigarette. And you can see here a modernized version of this ad, a young person kind of with his Juul ad again. So not directly placed in the school, but looking very similar. And again, at this testimony before Congress, young people actually came and talked about Juul representatives coming to their school under the veil of a tobacco cessation conference at their school and education setting and being told that these are totally safe. So again, we know that they're out there, they're in schools, and they're targeting young people directly. So I was hoping we could all pause here for a moment and think about the science behind these trends. And that's really where we're going next in the second quarter or so, or middle half of this talk. Which is, and to ask the questions, why are adolescents using at such high rates? And why is it that Big Tobacco would spend so much money to recruit adolescents to their ranks? And I'm hoping as we kind of gain a better understanding of the science, we'll be able to apply some of that to our work, both in our clinical settings and also potentially in the policy realm as well. All right. So we're going to start with just a basic understanding of the developing adolescent brain. And actually, I'll ask you all, if you're willing to write some words that come to mind when you think about adolescent brain development into the chat, because I'd love to kind of hear about where you're coming from with this. What do we think of when we think about what the adolescent brain is doing? And as you can see in this kind of time-lapsed photo with fMRI showing, there are some rapid changes. It's a sponge, I love that. There are some rapid changes that occur to the brain and what we know now, well into young adulthood. So previously it was thought that the brain stops developing in early childhood at some point, but now we know that well into the 20s, the adolescent brain is still developing. I love seeing words like malleable, still developing. I'm also seeing other things, and we can also see rapid growth. And actually what I'm showing here is interesting. I'm showing you gray matter, which is that top surface layer of the neuronal cell bodies. And I'm actually showing you decreasing amounts over time. So as it becomes more blue and green, there's decreasing amounts of that gray matter over time, so lower density of it. And what's happening is that underlayer, the myelin, the connections are growing rapidly, and the gray matter is being pruned over time. What we're seeing is this neural remodeling, this plasticity that occurs. And at that time, the last things that develop are these frontal areas of the brain. So I'm seeing manic, I'm seeing impulsive, I'm seeing words like impulsive, and actually those were in the chat here, and what actually those words really aptly describe what's happening. These frontal levels of the brain, this prefrontal cortex, the place that's responsible for executive function and some of these higher connections are not yet fully developed until about age 26, as I see some people mentioned here. So those decision-making skills are still in process until the 20s. The other thing that's going on in the brain is that those reward centers are really high. So I saw the word manic come up. I think that's a really nice way of describing this. It's a high energy state, high reward, and it's a time in our lives when we have the greatest reward for some of the things that we try. So I'm not sure if other people have seen this book. It's by Dr. Frances Jenkins. She's a neuroscientist. And she actually refocused her area of study as her own adolescents, for her own children were becoming adolescents. And she refocused her area of study on the adolescent brain, and she wrote this book, The Teenage Brain, and she calls it, I want to make sure I get this right, so I'm going to move my chat, The Teenage Brain, a neuroscientist's survival guide to raising adolescents and young adults. And I saw her speak actually at a Mayo Clinic Grand Rounds when I was working there as a general pediatrician. And she talks about the way that this understanding of adolescent brain development really reshaped the way that she thought about her own children's behaviors as adolescents. And she describes the adolescent brain like a Ferrari with weak brakes. So this kind of rapid going, go, 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 but really without the brakes on yet to stop its course. Or to stop these decisions. So it's this beautiful time of social development. It's this time of rapid learning. It's this time of sponge-like learning and behavior, but those decision-making skills, the brakes, so to speak, on those reward pathways aren't really there yet. And it's important that we know that the adolescent brain is not like a mini adult brain. It's not fully developed quite yet. All right. Here we go. And I really, I like this image from UNICEF, and they talk about that early adolescence in particular, but I would argue adolescence in general as a second window of opportunity. And I actually think this is a cool way of thinking about it. So it's this beautiful window of opportunity with rapid learning, brain development, social development is key at that time, as some people said in this chat. But it's also a period of risk-taking behavior and vulnerability, because that neural remodeling is going on. So I think thinking about the adolescent brain in that way is a really important kind of construct here. And again, I think they use the term here, sensation-seeking motivation for social relations and sensitivity to social evaluation. And I think that really can help us frame some of the behaviors we're seeing during adolescence. Thank you all to all who participated in the chat. So now let's talk about what happens when nicotine comes into play. So we now have some really good science, some from combustible, traditional, conventional tobacco, and now more recent knowledge about how e-cigarettes kind of fits into this, about how nicotine affects the brain itself. So we know that there are some physiologic changes that occur, some pathophysiologic changes, I would actually argue, that occur when nicotine comes into the brain. One of the things that we know happens with nicotine is that nicotine binds to acetylcholine receptors. These acetylcholine receptors are present all throughout the nervous system, in the central and the peripheral nervous system. There are about 12 different types. And again, I'm not a neuroscientist, but broadly speaking, when nicotine binds to one of these receptors, it changes its conformation, it opens up the pore in the cell wall, and it allows cations, so ions, to go in, and it excites the cell or energizes the cell. And this can lead to changes in the neurotransmitters that are released, and the one I think most about is dopamine when we're talking about nicotine. And dopamine is involved in cognition, it's involved in reward centers, it's involved in kind of a lot of this executive function and this higher function that we're talking about. And it's involved in the well-known and well-established reward pathways. And we know that with repeated exposure over time, nicotine receptors, the number of nicotine receptors in the brain actually increase. And we think that this potentially contributes to dependence, because more and more nicotine is needed to get the same effect, or to feel that reward, or to feel that excitement. Okay. And I want to talk a little bit about the way that nicotine actually affects the brain at a structural level. And there have actually been some really great studies that show that over time, nicotine actually leads to structural changes in the brain. And what I'm showing here in this picture in yellow and red here are the salience network and striatal reward networks, which are known to be directly involved in some of the reward pathways that we think about a lot with addiction and dependence. And these are the same, the study that I'm citing here actually by Hobkirk et al. Essentially shows that e-cigarettes have the same effect, many of the same effects on the brain and affect the same areas as traditional combustible cigarettes. So they're not unique, which is not surprising. Unfortunately, we also know that e-cigarettes have very high levels of nicotine, and I think it was mentioned nicotine salt, so the different types of nicotine that are used in the different devices oftentimes represent a much higher level of nicotine that can lead to an even greater effect. And we know that the areas affected in the brain are oftentimes involved in cognition, motivation, and executive function and mood. So again, over time, we start to see these structural changes to the brain. I wanted to quote a friend and colleague of mine, Dr. Lucien Gonzalez, who recently at a Minnesota American Academy of Pediatrics webinar called nicotine a cognition chemical. I actually think that's a really useful way of thinking about how nicotine plays into it. It's not just a reward or an addiction chemical, it is a cognition chemical. It changes the way we think. And the adolescent brain, as you might imagine, in this rapid period of development is particularly vulnerable to the effects of nicotine. So when we think about those, those neural changes and those structural changes that occur, the adolescent brain is particularly vulnerable to these changes. So much so that we know that when a young person starts using nicotine during adolescence, during this rapid phase of development, they are much more likely to become addicted for life. And in fact, the earlier they use, the more likely they are to be unable to stop. So when we think about those middle schoolers, those sixth graders who are using, about 2/3 of them will go on to become regular adult smokers or users of nicotine. And we know that about nearly 1/2 of the 11th graders who I mentioned earlier will go on to become regular adult smokers. So again, going back to that original story I told you about that high schooler, that young man who I was seeing for anxiety and cigarette use, it's very likely, actually more likely than not, that he will go on to be a regular smoker like his parents were. And I wanted to talk a little bit about the order of symptoms of dependence. And I know there are a lot of people on this call who work with young people who struggle with substance use and adults who struggle with substance use. So this will look familiar to you all. But essentially, symptoms of dependence with nicotine arise in a predictable order. So it starts with a general wanting to smoke, goes to a stronger, more intense craving. And then the third kind of symptom to develop is a needing to smoke in order to avoid withdrawal or to even feel normal. And this has been well described in the literature, dating back to early studies of traditional combustible cigarettes. And when we think about e-cigarettes and about adolescent use, the strong urge to smoke and the withdrawal symptoms start to occur well before the young people start to even recognize that they feel addicted. So when we think about this order of symptoms, just asking about addiction is not sufficient because young people may not recognize that strong urge to smoke, those cravings and those withdrawal symptoms as addiction. So again, for those of us who work with young people, work with adolescents, or are thinking about these issues, we really need to be thinking about this early on and identifying these symptoms of dependence early on before they feel addicted and before they feel like they're at a point where they can't quit, quote, can't quit. And again, thinking about the uniqueness of adolescence and this time of development, symptoms of dependence arise very early. And again, these data are from studies with traditional cigarettes and traditional nicotine use, but what we've seen are that very early on, even in the first month, about 1/4 of young girls and about 10% of young boys will start to show signs of dependence with traditional cigarettes. And now with e-cigarettes, we have increasing evidence that with the higher levels of nicotine, especially in Juul, people are likely to become dependent even earlier. And some have suggested that they can become dependent even after a few puffs or a few uses. And symptoms of dependence in adolescence can arise with even intermittent use. And I think this is a really important point, and it's something that I underestimated when I was first seeing young people who were using. What we've realized now is that even with intermittent use, less than 1 time per week, about half of young people at that point started to show signs of dependence. So again, catching this early and recognizing that early intermittent use, people who are using only intermittently, should still be screened for signs of dependence, and we can still be providing support at that moment. And again, that's in some cases unique to, especially true in adolescence. And this comes back to a new model called the sensitization homeostasis model that suggests that in adolescence, this early intermittent use increases the risk of later dependence by tenfold, signs of dependence by tenfold. So not only are adolescents particularly susceptible to early signs of dependence, not only are they more likely to become addicted even with only intermittent use, they also have long-term changes in cognition and behaviors relating to that ongoing rapid development. So we know that over time, and this dates to animal models, which is why I have my little mouse here on this slide, but now has actually also been shown in some human models as well. So we know that nicotine use during adolescence predisposes to changes in memory, is associated with changes in attention, in auditory processing, in impulse control, and also anxiety and depressive symptoms, and finally also with sleep. So it changes the structure of sleep, changes the amount of REM sleep, and changes in periods of wakefulness by increasing those periods of wakefulness. So for those of you who are mental health providers or people like myself who work a lot with young people who struggle with mental health issues, these long-term changes in cognition and behaviors are very real and could be affecting and impeding their treatment processes. And I think I missed that with that first young person I saw, that his anxiety it was very likely being worsened by his e-cigarette and nicotine use. This is really problematic, I would argue, because what we know now, as I mentioned earlier, people with mental illness are more likely to go on to use e-cigarettes. And many of the young people I work with actually talk about starting to use nicotine because they feel it relaxes them and it gives them a little high and it helps them escape in some way as they think about using other substances as well. But it also predisposes to many of the symptoms that we talked about. There's actually some evidence now that shows that with chronic nicotine use, there actually is increased cortisol as well. So again, it's this bi-directional relationship, and we should be thinking as mental health providers, as clinicians who are working with young people with mental illness, are we thinking about how their nicotine use is actually affecting their mental well-being? It is bi-directional. Okay, so with that in mind, I want to pause and reconsider the questions I posed earlier. Why is it that adolescents are using it at such high rates? And why is it that big tobacco is spending so much money on adolescents? And I would say it's probably because they know that when they hook adolescents, when they can hook people early, they're much more likely to become addicted for life. They're likely to become addicted quickly. And they know the data that 90% of current cigarette users started during adolescence. So with these devices that infuse a high amount of nicotine and expose adolescents to a high amount of nicotine, they know that they can catch them early and hook people early and recruit them to their ranks. And I think this can really inform the way that we have these conversations with young people, even those who are using only intermittently. Okay. So kind of with that context, and in light of that context, I'm just checking my timing, perfect, we're about halfway there. So in light of that context, I want to think a little bit about now the intersection between substance use and nicotine. So we know now, and it's well established, that nicotine primes the brain for addiction. And this first was shown epidemiologically, where we saw that people with substance use disorders, as I mentioned earlier, people with substance use disorders were more likely to be using nicotine, and people with nicotine were more likely to be using substances. We knew that, we observed that epidemiologically. So we saw that empiric trend. And we then saw that in animal models, so we'll talk about a little mouse, we know that with mice who are exposed to nicotine, they're more likely to become dependent on cocaine, methamphetamine, alcohol, and other substances. So we know that adolescent exposure to nicotine in mice went on to predispose to addiction, more vulnerability to addiction to other substances. And this has now been extended to human models or to humans as well. And we see this trend that young people who use nicotine are more likely to go on to use other substances too. And we now actually have we have a better understanding of the neurobiologic underpinnings for what's called the gatekeeper model. And you can see this gate here. We know that nicotine, so to speak, opens the gate. And we've actually now, the research has actually now started to identify genes that are involved in this process. So genes that are mediated by nicotine use that predispose to vulnerability to other substances. So again, nicotine primes the brain for other forms of addiction. So again, let's go back to this slide I showed earlier. When we think about the fact that 20% of adolescents who use e-cigarettes have signs of severe substance use, this is not a surprise, because young people who use nicotine aren't just more likely to be maybe hanging out in circles where other substances are used. Their brains are actually primed to be more likely to have to develop signs of substance use disorders. So again, this is not an accident, and it's not a surprise in light of what we know about the neuroscience. And I wanted to speak specifically to the link between nicotine and opioid use disorders. So we know that nicotine and opioid use are linked, and this has been, again, well established empirically in epidemiologic trends. But what I find very interesting is what we now know is that these addictions and this dependence and these uses are mutually reinforcing. So people who use nicotine are more likely to go on to misuse prescription opioids. And those who are using opioids are more likely to report having used nicotine as well. So they're thought to be mutually reinforcing addictions and mutually reinforcing dependence. What's also interesting, and I think to take this a step further, even beyond adolescents using nicotine being an increased risk for opioid use, we've now gone even further. And there have been some recent studies in the last decade that have shown that actually for those who are undergoing treatment for opioid use disorders, when they quit smoking, they're more likely to be successful in their treatment course. So again, smoking cessation helps improve nicotine dependence treatment. So for those of you who mentioned that you work with young people or adults that are vulnerable to substance use, what we know now are that quitting smoking actually could help with their other substance use treatment. And I think this is actually a really important point and might reframe the way we think about youth tobacco prevention efforts, and we'll talk about that in a little bit. So with all that in mind, we've talked so far now about nicotine, the nicotine's effect on the brain. We've talked about nicotine specifically in the context of this rapid period of brain development. We've shown that adolescents in particular are vulnerable to nicotine addiction, become addicted more quickly, and are more likely to show signs of dependence earlier on and even with intermittent use. We've shown that nicotine leads to an increased risk of other mental health symptoms. And now we've shown that nicotine primes the brain for addiction to other substances. So kind of thinking, I want to now transition in this final phase of our conversation to thinking about what we can do about it. Okay, so first I think it starts with reframing tobacco prevention and tobacco use efforts as primary prevention for some of our mental health and substance use conditions. So for those of us who are working with young people with mental illness, if we think about having them quit smoking or helping them and assisting them in nicotine cessation and tobacco cessation, we might actually be able to make a big difference for the later prevention of the prevention of later substance use and mental health issues. So again, I think this takes somewhat of a paradigm shift because oftentimes the tobacco world is kind of siloed and thought of it as its own thing, but I think we really need to be thinking of them in a more integrated way. And it starts with asking the question. And there are many different ways to ask the question. There are validated screening tools out there for nicotine and other substance use. Many of you are probably familiar with them. I happen to really like the Graph Plus N for adolescents, which integrates general screening for use with problem use symptoms and behaviors. And that's through Boston Children's. But it does start with asking the question. And right now, and this is from a CDC report in their Morbidity and Mortality Weekly Report, we know that about just under half of mental health facilities in 2016 and about 64% of substance abuse facilities were even screening. So at this point, even our mental health and substance use facilities are inconsistently asking. And these include all of substance use facilities for both adolescents and adults. And the American Academy of Pediatrics recommends, of course, that all primary care clinicians, for those of you who are in the primary care role, be asking consistently as well. One model that's been well described in the literature is the 5 A's model. So many of you may be familiar with this, especially those of you who've who've done some work with nicotine dependence before. And this is endorsed by the American Academy of Pediatrics as well. And what this model starts with is asking the question, as I mentioned. So first, do you currently smoke or use other forms of tobacco? Do you use e-cigarettes? I think are easy ways to kind of start by asking. And if they answer yes, asking what kinds of devices they're using, and what kinds of nicotine they're using and where they're getting their devices. It then goes on to the second step of advising, and they talk about advising with strong, personalized, and empowering language, and meeting the young person wherever they are kind of in their own stages of change, but kind of providing a strong recommendation that empowers the adolescent to make a change if they want to. It then involves assessment, and this includes assessing motivation, confidence in their ability to quit, documenting prior quit attempts, and then documenting the severity of nicotine dependence. And though not the focus of this talk it's not the focus of this talk to go through validated screening tools and things, but I'm going to share some resources where you can easily access those. But thinking about kind of doing a little bit more assessment about what exactly is going on at that point and where they are in their stages of change. Fourth A is assisting, and this includes assisting them with wherever they are in their stage of change. So for the young people who are in contemplation, who are at the point where they're thinking about maybe quitting, but aren't really at the point where they want to make a big change yet, it's even providing a brief intervention and assisting them with connecting with some resources and information if they want it. But for those who are actually thinking about quitting or have tried to cut back, it involves assisting them with connecting with resources that are evidence-supported and evidence-based to help them quit. And I think the final A, I would argue, is actually among the most important, as kind of a pearl and take-home point, which is arranging follow-up. Close follow-up has been key, especially for those of us who have ongoing relationships with these young people. They may not be at a point when you first meet them to be thinking about quitting, but continuing to have dialogue, to follow up, to let them know that you're there, and to be a source of support for them is really key. So again, assisting them with connecting with where any resources, or connecting with or making some goals around next steps, and then having a follow-up point where a moment in time to actually talk to them and reconnect. I wanted to briefly touch on some of the treatment options that are out there. So among the best studied for adolescents are behaviorally based interventions, and many of you are very familiar with these, so these should look familiar. They're used in other substances, and they're also used in other mental health counseling as well. Motivational interviewing is well studied in adolescents. Problem-solving skills are a key component. Support and encouragement, so just that support and encouragement can make a big difference. Cognitive behavioral strategies can also make a big difference, and when we think about this, we think about specifically about self-monitoring and coping skills. And then social influence strategies, and these involve identifying social influences that promote or maintain smoking and helping to adjust and helping to find other sources of support in social influence. And I think though these are relatively simple things you can do in a fairly efficient manner, they can be easily integrated into our visits with these young people. Unfortunately though, behaviorally based interventions can really only go so far, and they really work best when people are only showing mild symptoms of dependence. We also know that there are some pharmacologic interventions for young people, in particular for adolescents with signs of moderate to severe dependence. Nicotine replacement therapy has been shown to be effective and has been well accepted by the American Academy of Pediatrics. It is not currently FDA approved, but the AAP and experts in this field absolutely recommend considering nicotine replacement for those with moderate to severe symptoms. And unfortunately, it's underutilized, as many of us in pediatrics don't really get training in this, because thankfully this was an epidemic that was going down, the epidemic of nicotine use. And now in the past 5 years, we're seeing a resurgence of people who are increasingly addicted. And I put a little asterisk here to highlight the American Academy of Pediatrics Richmond Center, who has a whole abundance of resources that are free and available to those of us working with young people who may be dependent on nicotine. And they actually, in December of 2019, came out with a very specific and nuts and bolts style fact sheet for nicotine replacement therapy for adolescent patients. And if we have time, I can pull that up and screen share so you can see what that looks like. Other medications that you may have seen used in adults, like varenicline and Wellbutrin, are not typically used in adolescents for nicotine dependence. Pretty much the only time I've seen Wellbutrin used or used it myself or when I'm treating for a co-occurring mental illness where I'd consider Wellbutrin otherwise in somebody who was using nicotine, but I'm not using it for the sole purpose of nicotine dependence. And in fact, there have been some recent studies that shown that they're not very effective for adolescents as well. So again, let's think together about our roles, specifically knowing that there's a lot of social workers, mental health providers, and substance use treatment professionals on this webinar. What can we all do about it, and where do we fit in? I would actually argue that you're very poised and well positioned to fit in, and that you have a lot of these skills already and are well connected, but you also have a lot on your plate. And we know now with the current state of affairs that about 38% of mental health facilities and just under half of substance use facilities are currently providing smoking cessation counseling. So there's certainly room to grow, knowing what we know about the links between mental health, substance use, and nicotine use. And about a quarter of mental health and substance use facilities, and this includes young adolescent and adult treatment facilities, will provide nicotine replacement therapy. And even if you're not at a site that is providing that exact counseling or therapy, we absolutely, there are actually absolutely resources out there to connect young people with. This one is one of my favorites, is from the Truth Initiative. And it's the first, as they describe it, the first of its kind program to help young people quit vaping. It is a text line that can text ditch Juul to 88709. And they say to leave your Juul or other e-cigarette behind. And I really like this resource actually for all of us clinicians because there's tons of resources available on this website, fact sheets, and it actually connects young people with the community as well. And I also wanted to highlight, this is Mayo Clinic's Become an X website, which will actually allow people for free to connect, come up with a customized quit plan, include text messages for support to support quitting, smoking and vaping, include interactive guides, advice and tips, and then also connect them with a community who's recently quit. And I didn't highlight here the Minnesota hotlines and the national hotlines, like Quit Now hotlines and tobacco cessation, because I'm trying to focus on very youth-friendly resources. I wanted to briefly, before we close this formal kind of didactic part of the talk about policy level changes, because nicotine dependence does not occur in a vacuum. And we know, and the Surgeon General has put out that coordinated and multi-component interventions are really key. So I'll talk through some of these. We know mass media campaigns have been launched, and actually some of the adolescents I've seen recently have said they more often now see media campaigns against vaping than they actually see websites, advertisements for vaping in their social media. So in that case, I think we're winning a little bit. Tobacco tax increases. So we also know that increasing tobacco taxes do reduce tobacco use. So, and thinking about having e-cigarette taxes be approximately the same as conventional tobacco products, which are not the case currently. School-based policies and programs, I've been involved in some of these, and I think in Minnesota we're doing a great job with some of this work, and I think especially knowing that many people are starting to use e-cigarettes in schools during class, where to the extent that I actually will sometimes see plumes of smoke coming out of bathrooms in the schools where I work. These school-based policies and programs are really important too. Smoke-free policies in different sites are important. Tobacco 21, so I have some new updates as of the last few weeks actually. As of just before the new year, there's actually now federal statute that mandates 21 years of age for retailers to sell tobacco. Unfortunately, a lot of our young people, including e-cigarettes, unfortunately, a lot of adolescents are purchasing these online where it's not as closely regulated, but still, we're hoping that this will curb the amount of access that young people have. Limitations on advertising to young people, which exist already, but kind of strengthening those and enforcing them. And then limitations on flavoring cigarettes has also been kind of talked about at the local, state, and national levels too. All right, so we'll revisit our objectives here. So for the first objective, which was trends in adolescent e-cigarette use, we know that adolescent e-cigarette use is on the rise. We know that young people with mental illness are at particularly high risk, and those who use substances are at particularly high risk. The second objective was about the developing adolescent brain and getting a better understanding there. And what we learned is that it is vulnerable to nicotine and that their teens are more likely to become addicted, remain addicted, and have lasting neurocognitive implications. Thirdly, Nicotine and other substance use, when we thought about that, nicotine primes the brain for addiction, especially when exposed during adolescence. And I think this is really important to rethink tobacco use and tobacco use prevention and cessation efforts as primary prevention for later mental health and substance use, knowing that it can help with treatment. And fourthly, clinical and community-based strategies. We know that there are several promising behaviorally based interventions, especially for those with mild dependent symptoms, including some of the resources I shared today. And for those with moderate to severe dependence, nicotine replacement therapy should absolutely be considered. And I actually already see a question popping up here about nicotine replacement therapy having the same effect on anxiety and as nicotine and tobacco products and e-cigarettes. I think that's a really, really, really good point. Absolutely. When we're thinking about nicotine, that nicotine is the same as, sometimes to a lesser extent, but lesser amount, but the same that might be used in the same product that might be used in other tobacco products. And we need to talk to young people and be monitoring very closely as they're thinking about quitting. And actually among adolescents in particular, not only anxiety symptoms, but depressive symptoms and suicidality can actually increase as we're starting nicotine replacement therapy and thinking about smoking cessation. So having really strong mental health support around them as they start to transition from e-cigarettes and combustible tobacco products to nicotine replacement therapy and then hopefully off. We need to be thinking about providing really strong mental health support. But the goal is with nicotine replacement therapy to slowly decrease the amount of nicotine they're getting over time, which ultimately improves those mental health symptoms that may have worsened with nicotine. And finally, policy changes are likely to curb that trend. Thank you for your question. I figured I'd jump in with it because we were talking about it. All right, and again, we're close to walking out of this webinar's virtual door today, but big picture, we all have a role to play in this, no matter where we are. So I hope you all have thought a little bit about what you're hoping to take away. And in addition to questions, I would love to hear from you all in the chat what take-home points that you're leaving with and what you found the most useful today that you'll think you'll take away with you as you walk out the door. So thank you for sharing those if you have key take-home points. And I'll share my references in our slides as well. But thank you so much, and thank you so much for your attention and for engaging with me. And I'll take questions at this point. And I think we have about 5 to 10 minutes for questions, if that works. Am I right, Joe?
Yes, thank you, Janna. Peter says, I've also heard about salt nicotine, which I understand delivers a higher dose of nicotine. Can you talk about the difference, please?
Yes, and I can send out a little of information about nicotine salts together. I think broadly speaking, there are several different types of nicotine products. Nicotine salts are oftentimes purchased on the black market and are around. And some of the types of nicotines are some of the nicotine products and nicotine liquids have higher amounts of nicotine than others. The ones I see most commonly used actually among adolescents are those that are in the Juul products, and those we know have much higher than a typical combustible tobacco cigarette. And absolutely salts have higher amounts as well. And again, each of the products that I kind of showed and mentioned have slightly different amounts of nicotine that they use, and actually the type of device that they're using will also affect the amount of nicotine that's out there, that's in the device or that their adolescent is getting. And I want to actually make the jump from here. I think this is actually a really important point. The focus of this talk was not on how to do nicotine replacement therapy, but because the different e-cigarette products and electronic nicotine delivery systems kind of complicate how much nicotine people are getting, we oftentimes will have to kind of titrate the amount of nicotine we're using and do that kind of best guess estimates as to how much nicotine they're actually getting on a daily basis, because it's oftentimes not totally clear on how much they're getting. And the amount of nicotine the adolescent is getting kind of varies not only by the nicotine content of the liquid that they're using or the product, like the salt versus a liquid, but also by the type of device that they're using. And I think this is where the Richmond Center has some really great resources.
Thank you for the very thorough answer. And Julie asks, does NRT have the same effect on anxiety as the nicotine in tobacco products such as e-cigs?
That's a really good question. That's the one I was mentioning before that I saw. So absolutely, yes. So nicotine in general, whether it's in an e-cigarette product, a combustible tobacco product, or a nicotine replacement therapy, can be associated with those increased anxiety symptoms. And again, as I As I mentioned, as people are going through kind of the tobacco cessation products process, especially those with moderate to severe dependence, we can see heightened mental health symptoms right in that time of quitting. So having that really strong mental health support initially and coupling and working with our mental health colleagues, if you're not a mental health professional to begin with, is really important. And young people who I'm treating with nicotine replacement therapy or otherwise, I'm seeing back very closely. That close follow-up is really important, and monitoring those anxiety symptoms. Ultimately, the goal is to slowly decrease the amount of nicotine that they're using, and nicotine replacement acts in that way. It allows us to slowly titrate without the downsides of the other additives and other toxic effects of the chemicals that are in non-nicotine replacement therapy products. So things like e-cigarettes and combustible products. Does that make sense? So the advantage is it's without the other downsides of other additives. That get us? All right.
Thank you, Janna. Two more questions here, quick. Laura asks, how do use and treatment trends differ with marijuana vaping?
Oh, great question. And I avoided this in the talk for the sake of time. So marijuana vaping adds another, so you can absolutely use marijuana in some of these devices. We know that a lot, again, my focus here was not on the pulmonary effects, but a lot of the recent epidemic of vaping related acute lung injury was oftentimes occurring when people were using off-label devices, not off-label, black market devices, and other smoking marijuana in the devices and other products that weren't intended for those devices too. But I think when we're talking about marijuana, we're talking about an additional layer of dependence. So I conceptualize it as intersecting substance use disorders. So it's the nicotine use disorder, but then also marijuana use disorder together. And when I think about the way that that affects the treatment, I'm thinking again about integrating some of the things we know are useful in marijuana use. And thinking about how the marijuana that's been involved might be at play when we think about why they're using. So many people that I work with, many young people that I work with who are using marijuana in these devices or otherwise are using them again to treat their mental health conditions and to self-medicate. And I work a lot on co-managing with my mental health professionals in those situations. So again, I start to think about them as co-occurring substance use disorders and treating them both together, looking at the whole picture. Not sure if that answers everything, but it's tricky.
Thank you, Janna. Karina asks, I had a question today from a patient. What is your opinion on vaping essential oils in order to quit vaping nicotine?
Oh gosh, yeah, I've been asked this a few times by adolescents, not as much as I would have expected actually. So I frequently hear from adolescents that they're not using e-cigarette products that actually contain nicotine. So they'll be like, oh, I'm using low nicotine or nicotine-free devices or oils that they purchase that they don't think contain nicotine. First off, I want to just share that 99% of current e-cigarette products on the market actually do contain nicotine in them, and they're oftentimes mislabeled. So even those that are marketed as nicotine-free oftentimes do contain nicotine. So my first concern is they think they're on something that doesn't contain nicotine, but it actually does. In terms of essential oils, I get nervous about the inhalation, the effect of inhaling essential oils or any product that's not FDA regulated. Where are they getting the essential oils? What other products are in them? And what effect does it have when they're breathed in? So again, smelling an essential oil, having an essential oil around, or using it on the body and rubbing it in is different than inhaling it into the lungs. And that makes me quite nervous in terms of the other physical effects of inhalation of products that aren't regulated. So I'd have to get a little more information on what they were with this young person about what kind of oils they were using, where they were getting from, and what those products are for. Oh, I have another question here too. Does that answer, Karina, sorry, does that answer your question a little bit? I know it's kind of a wishy-washy one. Kind of depends. Okay, perfect, thank you. Can nicotine alone cause cancer? So the cancer debate. So we know that combustible tobacco products cause cancer, and we think that combustible tobacco products like cigarettes and conventional tobacco products cause cancer because of the other additives or the other exposures that are part of the device. It's not the nicotine itself. E-cigarette products have been on the market for shorter periods of time. So I have not seen good studies showing that e-cigarette products are associated with cancer long-term. That being said, we know that many of the same additives that are in traditional tobacco products are also in e-cigarettes. And we know that some of those chemicals are associated with long-term cancer use. So from a theoretical perspective, we know that there is this potential increased risk, but e-cigarette products are not actually, have not been around for long enough to draw a clear association with cancer at this time.
Thank you, Janna. A couple folks reached out and asked if you would be able to rewatch this recording. Absolutely, it'll be on our website. That information will be in the email you receive within about an hour. And on behalf of the Center for Practice Transformation, we'd like to thank you all for joining us for the first webinar of 2020. And we'd like to extend an extra special thanks to Dr. Janna Gerwirtz-Obrien for sharing her time and talents with us today.
Thank you so much for having me, and thank you to all of you for engaging. This was great. I appreciated the conversation.
Thank you all again. Have a safe weekend, and we will be in touch.